Mary will not be able to join us today. We tried to get her for this, but she is out with Quincy doing a training, I believe, at Henry J. Austin.
Oh, okay.
But we are going to record it for her because she was super excited to hear that we were showcasing all of the great work you guys do and how to leverage you even more than your sites already are.
Oh, yeah, stab him.
No, you don't like me.
Oh, wow.
So just so folks know, we've got Greg here who's managing the technical side of our webinars. If you are able to mute yourself, go ahead and mute your line. But if we hear some background noise coming from you, we're likely to mute your line for you. So if all of a sudden you can't talk, that's because we muted you. But don't worry, we can unmute you as well. Hey there, Mr. Jordan. Hello. See how great it is seeing everybody's faces? Doesn't everybody want a camera? Right, I saw that Post-it note go up, Marianne. All right, so just as a reminder, as folks are joining us, if you could go ahead and use the chat room to let us know that you're here. If you're watching this webinar with more than one person at your site, if you could just let us know everyone who's watching from your site so that we can keep an accurate record of who was all able to join us today. In just a second, I'll go ahead and start the record function. We do record these webinars, so we just want to make sure everybody is aware of that. So I will go ahead and hit that button now. Oh, Greg, you have to do it for us. Oh, Greg's got it. Awesome. So let me pull up our slides for today. Thumbs up if you can see the slides. Yep. Awesome. So what we wanted to talk about today, thank you all for taking time out of your day. We know it's really valuable and we appreciate you joining us, is to really take a look at how we could potentially be further leveraging community health workers to improve referrals and linkages for behavioral health care. This is part of our community webinars that we do every month. And we, like I said, we do record this webinar. So if there were staff who are unable to join you, we will be uploading this to Basecamp after this webinar. So you are free to download it and look at it anytime that you find convenient. So we just wanted to sort of start here with our combined HIV and behavioral health continuum as a frame for the conversation that we're going to have throughout today's webinar. So as you can see here, what we've done is we've taken our traditional HIV care continuum and the expected steps of behavioral health care and put those into a combined continuum. This combined continuum has more of an emphasis on the behavioral health care steps so that we could use the familiarity of a continuum into our behavioral health space. So you see that we begin all the way on the left of the screen towards the beginning of the arrow with behavioral health triage and screening, moving to diagnostic evaluation with a linkage to behavioral health treatment, followed by evidence-based behavioral health treatment, which we have as a goal of improving retention and engagement in both HIV care and behavioral health care. And it is our hypothesis that with greater retention and engagement in these two areas of care, that individuals living with HIV with co-occurring behavioral health disorders would see improvements in both their HIV-related outcomes as well as their behavioral outcomes. When you look under our arrow, what we have here is sort of a high-level look at how we intend and are measuring the steps in this process. For screening, we're looking at the percentage of folks that are screened for behavioral health disorders, followed by the percentage of those with positive screens who have follow-up or a diagnosis documented, looking at the percentage of internal care and external referrals in some cases, looking at the percentage of those who are diagnosed who have a behavioral health disorder with a treatment plan located inside their primary care record, those who have follow-up to that treatment plan, and then at the end of the day, always making sure that we keep our focus on outcomes, the percentage of those diagnosed who have some kind of documented improvement. And if you look at our BHIP performance measures, these are all aligned around trying to measure and identify areas for improvement and areas of success in those spaces. One of the things that's important to know about our process currently is that in the first part of the BHIP project, we were really looking at the screening phase. And now, as you see at the bottom of the picture here, we're moving more into our referral phase. Sites were asked to conduct an activity related to referral mapping. And at our most recent learning session, we were able to use those referral maps and our process maps as a way to begin identifying potential gaps in our services. Where do we send people where we don't know what happens to them, where we're creating black holes, or where might there be bottlenecks in our process where we're dependent on a single staff member who has such a high load of work that it's actually stopping our process from moving forward. So what we wanted to take a look at for today is how are community health workers being leveraged and how could they be leveraged to support these gaps that we tend to find in behavioral health care. We hear anecdotally from sites that there are a lot of challenges linking people to care. Some of those reasons that have been cited is a lack of certain care providers to be able to send people to. But what we also hear, and I hear this at least in the case of the sites I'm working with more often, is that there's sometimes a discomfort with the patient or the client accepting the referral into healthcare. Or a visit is scheduled and they don't follow up. They don't make that first visit. Or potentially they make that first visit and then they don't go back. So what we wanted to look at is how is New Jersey's community health worker program able to help with this gap? And what might clinics and organizations that have health workers be able to do to support greater retention and linkage to both behavioral health and HIV care? So I thought it was important that we start first with a broad overview of the community health worker program. I know most of our BHIP sites actually have community health workers in them, so this may be a little bit of a repeat for you, but for those who do not have community health workers, we wanted to make sure that you understood the nuance between how the community health worker program works in New Jersey versus how it works in some other jurisdictions. So this project was actually generated from a need identified by the New Jersey Department of Health to prioritize a community clinic partnership that would be a model of peer support. At the time, the former director, Loretta Dutton, reached out to the AIDS Education and Training Center and said, could you all research and find what are the best models of peer support around a community health work concept? And at the time, there were actually several large projects happening nationally, some of them in the special projects of national significance being tested in Ryan White settings around the topic of community health work. We often, in our systems, have a deep bench of peer models. New Jersey has had peer workers for decades. And so what we wanted to do was look at what are all of the potential models. How do we take what's working and add to it some other ideas that may come from other jurisdictions to create a community health worker program that would meet the needs of New Jersey while also pushing our current system to sort of rethink the way that we have sometimes traditionally used persons living with HIV and peers. We looked and selected an evidence-based program that had been demonstrated in Ryan White HIV/AIDS program systems of care. And this program was slightly adapted. It was first published in 2014, and so since 2014, we've had some pretty significant advances in our understanding not only of HIV care, but in HIV transmission and prevention as well. So we adapted the program so that it included information related to trauma-informed care, so that CHWs were aware of this aspect of a person's care and how important it was to be approaching persons with a trauma-informed mindset. We added sections around HIV-related stigma so that persons living with HIV who were working in CHW positions were aware not only of how stigmatization affects our clients and patients, but how stigmatization affects ourselves as workers inside of the system. We also added sections to include information about U equals U, making sure that the CHWs had an understanding of how undetectable equals untransmittable could play out inside a clinical care setting and inside a community-based organization. We also added sections that were related to team-based care. In just a second, as we look at the model, you'll see that one of the elements that was critical to this program was the formalized integration of the community health workers into the care team, as well as the assurance that they were able to document in the electronic health record so that their services, as well as their viewpoint and lens, would be part of the patient record itself. And then as you see at the end, we added health record documentation to make sure that this new service was being documented into the electronic health record in a way that was going to be meaningful, usable, and appropriate to be included in a patient health record. When we look at community health workers writ large, a lot of what we saw people doing, we integrated into this program. First and foremost, we define community health workers as persons with a shared lived experience. Our neighbors to the north, New York State, has a peer certification program where they defined and used this language of shared lived experience. And we felt that this was a really great way to talk about this. A lot of community health workers are also engaged in case finding and support, really being able to identify folks who are lost to care. Traditional street outreach models were like looking for needles in haystacks. However, when you're thinking about clinical outreach, you already know where the needle lives and you know the last haystack it was in. So it makes it a little bit more targeted and slightly different than what our traditional community outreach programs had been doing. We also saw in the evidence-based program that we selected that adherence and emotional support was a huge component of what the CHWs were doing in this program and seemed to be really critical to assuring the outcomes that the program got. There's also a component inside their programs that were related to social networking for wellness, being able to help individuals identify more supportive networks in their communities where they would be able to, after adopting new behaviors, stepping more into wellness, that they would have social networks that would support them in this process, understanding how important it is when individuals are making a change in their life, that the people around them support that change, and that the CHWs could help assure that safety net, not only inside our CBOs and our clinics, but making sure that our patients and clients and people we serve were supported outside of the clinics and CBOs as well. We also felt that it was critical that CHWs had the ability to access and document in the patient record. Often we create silos with our information, where one provider may be aware of something and a community resource may be aware of something different. And sometimes those two data points were in conflict, or sometimes they were just unknown to the other side of the house. And we wanted to make sure that CHWs were able to integrate that data so that whatever somebody knew about a client or patient's care was carried across the continuum of services that they were being provided. We did not want to support a fractured care system because there's really good data to show that fractured care systems lead to medical errors, and those medical errors actually end in a lot of really negative outcomes for people, including increased mortality. We also wanted to make sure that clinical organizations fully integrated CHWs into their clinical care teams. There have been many efforts over the years to integrate peers into clinical environments. Some of them have been successful, some of them have not. We recognize that some organizations carried baggage with a program like this. So part of what we were able to do was tie the funding to the ability to integrate them into the care team. It's not really good to bring a CHW in and then hold them over here. We need to make sure that their lens and their viewpoint is part of the actual care team, so that when decisions are being made about the patient's care and what things we're going to offer to a patient in a shared decision-making model, that those things are appropriate and also that they're tailored culturally to the people that we're serving. And CHWs are a really great way to ensure the cultural bridge between what you're offering and what people are willing to accept. We also saw that there was a lot of community level education. This is an area where our CHWs haven't done as much work at this point. They have been very busy inside of their organizations, but a critical component of CHW work is also ensuring that communities are educated, so that if there are individuals out there who are living with HIV, who are uncomfortable coming into care, or who may be uncomfortable testing, know that there are resources out there, there are supportive environments, and there are people who have their shared lived experience who are ready and willing and waiting inside of our systems to support them in a way that may be more effective and more respectful. So when we looked at this partnership, this was something different that New Jersey did that I think is part of the reason why our CHWs are so critical in being able to leverage them in the behavioral health space. The New Jersey program required that both clinical and community-based skills and networks were aligned together. clinical institutions often have a lot of policies that can be barriers to community-based work. We are often tied to our desks inside clinics. If you are in a high volume primary or specialty care environment, you will likely be tied down with your RVUs and your revenue cycles and everybody trying to keep you in a certain space. And so we wanted to be able to create a program that sort of forced that partnership so that clinics who wanted to seek this funding had to address the institutional barriers to providing this kind of service. We also recognized in this partnership that community-based programs already have existent networks and skills in community-based outreach. And we wanted to ensure that those skills were leveraged in this partnership so that as CHWs worked across the clinic and the community, they were each bringing to the table the different skill sets and expertise of these two environments so that the bridge we were creating would benefit from both environments people were working in. We also recognized that a lot of clinical sites were deepening the integration of their care services to include things such as clinical outreach. This is not unique to New Jersey. We're seeing this all across the country, and not only in HIV, but in a lot of chronic disease. Recognizing that the majority of people's healthcare takes place outside of our clinics, and recognizing that we needed to be penetrating into communities in a different way. But what we did not want to do was medicalize the process to the point where community outreach becomes ineffective. If all we do is transport our jargon out into a person's home, it's still jargon. And so we felt that CHWs were in a unique position to have this specialized skill set to make sure that as we integrated and deepened this clinical outreach, that we were also thinking about what makes outreach very different than what traditional clinical services were. And then ultimately, we recognized that our siloed approach to HIV care, this idea that clinics and CBOs were treating patients and clients and we're not talking to one another often about this, either sometimes because of poor historical relationships or sometimes because they were just really busy, that it really was up to a program to try and bridge the gap between these two places. So when we define community health worker, the definition that we work with that came from the American Public Health Association is that a community health worker is a frontline public health worker who is a trusted member of and or has an unusually close understanding of the community served. Our target goal was to put persons living with HIV in each of these positions, recognizing that beyond demographics, there is a shared lived experience in our community that can bring us together in a way that traditional healthcare providers and healthcare professionals were unable to do. And so we really made a concerted effort to reach into our communities and identify those individuals who were trusted by us or had a really close relationship with us, either as a member of our community or somebody who walked in our community with our permission and with deep respect for us, so that we would make sure that the faces people saw and the language that they encountered when they came into our system was language that was familiar to them, language that was comforting to them, and that services would go out in a way that were respectful to the various communities and cultures that they come from. So what makes CHWs unique and a little bit different? For better or for worse, it's that people from communities trust other community members quickly. We do not have as much baggage with the health system as sometimes healthcare professionals do. There are communities that still have very real historical traumas in place related to their communities and the way the healthcare system interacted with them traditionally. When you see someone living with HIV inside of the system working, you automatically have a little bit more credibility. You have one of us as part of you, and it allows people to feel more comfortable saying, if that person from my community is inside that environment, then this must be a safe place for me. We see this a lot in our organizations when we talk about cultural competency and cultural humility, that part of achieving a culturally competent organization is one that reflects the community that they serve. And this reflection often takes the place in making sure that the identities that you're serving are also part of your staff. CHWs also present an opportunity to be positive role models. When you see someone walking the walk and talking the talk, who has come from the places you have come from, who understand the challenges that you are going through and have made that choice towards wellness, you can really inspire others to do that. Part of the way that positive role model is established is because you give patients and clients access to someone who's been there, somebody who understands the walk that they're walking. Another critical role that CHWs play that makes them unique is that they can facilitate communication with medical staff. Sometimes we have the best doctors in the world, but they were trained in a certain way to have a certain kind of conversation. And sometimes that conversation gets lost in translation. CHWs are individuals who understand what both sides are saying and can operate sort of as a translator between those two spaces. Also, as members of the community, we sort of naturally have a focus on empowerment. When we see the people in front of us, it is a shift for us to think about them as patients and clients, because the people we see standing before us are members of our community. And what we want for our community is for every single person to be valued in their full expression of their self. And so a lot of the work we do, while supporting very important clinical outcomes, is really focused on making sure that the person from my community is doing well. We also thing that makes CHWs and community members in these spaces unique is the idea that they can use their personal lived experience and share that experience with the people sitting in front of them. I know when I did a lot of HIV prevention work, we leveraged a lot of our history as a way to communicate and coordinate with people the kinds of risk reduction plans they were going to engage in. When you have someone who can talk about being lost to care and coming back to care and what that meant for them and the challenges that they faced and how they overcame those barriers, it really helps people personalize that experience in a way that helps build self-efficacy and lead them towards this idea that they can do this too. So now what I want to talk a little bit about are what are the roles of a CHW, particularly here in New Jersey's program, and how could this help us address the continuum of HIV care and treatment services. So this is a graphic that was used by the Kaiser Family Foundation. I believe it came out in 2012. That was a way of sort of showing across the HIV care continuum, how did Ryan White services and service providers affect continuum outcomes. So you can see here when a person's living with HIV, moving them into diagnosis, that services such as HIV testing and counseling and outreach to engage in care, that those two service categories and those services are a way to sort of reach out and bring people in. Once we have a person linked to care, then you start seeing the value and benefit of services related to health insurance premium and cost sharing, non-medical case management, medical transportation, medical case management, and then referrals to other health and supportive services. And you see those are carried across the continuum, because once the person's in care, that service continues to support them. One of the unique things about the CHW program, however, is that CHWs don't provide case management. They don't provide treatment adherence support in the way we define it in our medical case management service category. They're not HIV testers. They're actually forbidden from their Ryan White service category to be providing HIV tests, because what CHWs are able to do is provide a through line through the entire continuum of services. As a person is being medically case managed, the CHW can be present with them. As a person is going to their social services, the CHW can accompany them to that visit, to be there with them as they're going through the process. After a person has had treatment adherence counseling, the CHW can be there with them to make sure they understood what happened in that session. They can offer their lived experience on how they improve their own adherence to their HIV medications or other chronic diseases that they may be dealing with. This is a critical piece of our program because there's really no one else and no other service that we provide that really has the beginning of the continuum of HIV care and treatment services all the way through towards wellness. This means that a single person now knows the patient and client's total story. Being able to bring that total story into a care team is a really valuable thing. It allows people to understand the full narrative of the person in front of them. It allows a person to advocate for what they believe the person wants to do and what they're capable of doing at this time. We don't want to create a paternalistic society, but what we do want to do is make sure that when care teams and prevention organizations and CBOs are meeting and discussing what's possible, that there's a person who has the whole narrative to help inform that discussion. So the CHWs provide a service, and that service, first and foremost, is emotional support. We aimed this entire program at not improving linkage and retention necessarily, but improving the experience of all other healthcare. One of the things that we have as our larger goal in healthcare transformation is really radically changing the experience of patients in their care, improving satisfaction, really looking at shared decision-making, so that as we're providing this care, it's appropriate and accepted by the people we're trying to provide it to. Out of emotional support, CHWs provide support in 3 areas. They can provide informational support, helping people understand what HIV is, explaining the importance of mental health care, explaining the link between HIV and depression, explaining to people what will happen to you when you go into a long-term residential treatment facility. A lot of us have been in these spaces, and so being able to communicate that kind of information to a patient or a client can be really critical in their accepting the service and staying in that service. They also provide instructional support. It is one thing to speak to a client about the importance of treatment adherence. It is another thing to be there every day in the trenches as they're taking that pill. Some of our CHWs have a list of people that they call every day, that they check in with just to see, how are you doing? Did you take your meds today? And if not, how can I help you do that? Again, this is all done with the lens of emotional support. We are not here to try and do a non-medical case manager's job. We are not here to do a medical case manager's job. They are very good at doing those things. What we're here to do is support a client even more through that process to make sure that everything goes in the way that we intend the service to be delivered. The last piece that CHWs also do is provide affiliational support. This is related to that social networking. Myself, I have a history of substance use, and I know how difficult it was when I stopped using to find a network of people who are going to support myself as a person not using drugs. Not everybody has the ability to connect into those new networks. Sometimes those networks are hidden. Sometimes they stay out of general public view because they're trying to avoid reoccurrence of their symptoms or their use. So having a CHW who knows how to walk both in the community as well as potentially a sub-community of individuals who are not using, who are gathering in their own spaces, this is a really critical piece that a CHW can do, which is build the bridge and establish affiliational support, which is exposing those networks to a person so that they're able to join that network and find the kind of support that they need. We also gave our CHWs 3 critical tools that were quite unique to them, but we felt were very important, especially in establishing communication and support with patients and clients. First and foremost, we wanted them to have cell phones, and we wanted them to be able to use those cell phones to text patients. We can download an app. It takes a long time. Sometimes clients and patients don't know their passwords to their phones. They don't remember their Apple ID, or they don't want to go into yet another application to have to communicate with someone. What they asked for was the ability to talk to people in the same way they talk to anybody else. So we made part of the program the ability to use unencrypted SMS-based communications, which is just a super fancy, inaccessible way to talk about texting patients. We wanted to help you be able to communicate to people in the ways they talk to others. We also recognize that transportation can be a huge barrier for people, not just accessing it, but what happens when it fails? When the Medicaid Logisticare shows up 4 hours late after the patient's visit, and someone's sitting there outside your clinic after the clinic is closed, trying to wait for transportation to show up that you're not even sure is going to be there in the next 20 minutes. That really affects patient care, and it really affects the experience of patient care. So we gave CHW special line items so that they could have recovery transportation services. When traditional Ryan White transportation fails, these services allow them to utilize special funds to bring the patient to the visit or get the patient home. This is done in many ways, sometimes through companies like Uber and Lyft. Some other local jurisdictions have actually contracted with local taxi companies. The important piece of this was, we're not taking over medical transportation. You still have to use all your Ryan White resources in the way that you traditionally do. This is for when that fails, when that doesn't work, or when they're 30 minutes late picking somebody up, because not only does that disrupt patient experience, it disrupts clinic flow. And that's a twofer that's really bad, and we wanted to affect that. The last thing we gave them was a line item that you would traditionally know as incentives, but we refer to them as facilitators to care. This is, if I have to be at a hospital all day long and I don't have anything to eat, that's going to affect my experience of that care, and it may affect whether I want to go back to that hospital for a whole day. The ability for a CHW in the moment to provide a meal to that individual, to meet their need at that time, was really critical to being able to shift the experience that the patient or client was having in the receipt of that service. So we made sure that they had that as well. We believe that these three things really help change the way patients and clients experience our services as a way that we can improve satisfaction and then keep people more retained in care. So when you look at the CHW tasks, what I've done here is highlight the things that I think are relevant to those of us who are working in the BHIP project, looking at referrals and linkages, and how could this be helpful. CHWs can do case finding and loss to care outreach. And when you think loss to care, think bigger than just HIV care. They may be in their HIV care, but are they lost to care to their psychiatrist? Does their therapist know where they are? Have they continued to go to AA or NA, which was part of their recovery plan? These are the kinds of things that we want BHIP to start asking and start answering, and where CHWs can be really helpful. You could offer CHW services to your referring partners. Hey, when our clients or patients disappear from your care, let us know. We have a CHW who we can send out and make sure that they're retained in your care as much as we retain them in our care, because we know these things are linked. CHWs can also accompany clients to medical visits, specifically mental health appointments, substance use treatments and visits, and social service appointments, all which we know are critical to their engagement in HIV care. They can provide education on the HIV viral life cycle. They can discuss HIV medications and treatment readiness, lab values, drug resistance and how it relates to adherence, sexual risk reduction, and drug use and harm reduction, right? When you're talking about delivering safer messages to people, harm reduction is something that has long been a skill of our community-based organizations. Clinical sites are getting better at it, but why not leverage the people in our communities who have been doing this for decades and reach out to your CBO CHW partner and have them deliver harm reduction services? They can also mentor and coach on provider interactions, helping people communicate more effectively with their providers so that their values, preferences, and desires are communicated in such a way that the provider hears them and integrates them into the patient care plan. They can also provide emotional support and informal counseling. Sometimes all you need is somebody there to listen to you. The other day, a CHW called us and said there was a client that was having a really difficult time, and she didn't know how to help him. She didn't know whether there was a service she could provide and wanted guidance on what she could do. And the guidance that I gave and what I would recommend for anyone is that the bare minimum that we can do is be present for people. Often people living with HIV have been dislocated from their social networks, their communities, their traditional houses of support. And what people can do for them, particularly CHWs, is bear witness to them, to be a person in their space who sees them. And I mean that in like seeing you way, not just physically, but emotionally, spiritually, connecting to an individual and being able to let them know that they are in this world, someone knows they exist, and somebody cares that they wake up tomorrow. That is often what a lot of people are looking for, and a lot of what people that sometimes walk into our spaces, unfortunately, because of stigma and discrimination, don't have. Another thing CHWs can do is also speak with clients about disclosure. Who better to learn how to disclose your HIV status than people who have learned how to do it, who have had to do this over and over again with their families, their communities, their churches, their sexual and drug-taking partners. These are conversations many CHWs are very comfortable with, and it's a way that you can provide from lived experience how to do this. CHWs can also help and assist with making appointments for HIV primary care, other health care, including mental health, substance abuse treatment, housing services, other support services, and accessing medications and scheduling transportation. These are all elements that a CHW can be helpful in. The one thing we would say, though, is don't duplicate something someone else is already doing. I know that a lot of organizations have linkage to care coordinators, non-medical case managers who work a lot in this space. Don't have your CHW do that work. Have them support that work that they're already doing. They can follow up with clients about a service or referral and make appointment reminders. Although when you think about follow-up, this isn't to be able to follow up in the way a medical case manager would. This is a follow-up to ask, how was your visit? How did it feel to be there? Did they listen to you? Were you able to say all of the things you wanted to say? Really attending to the experience of that visit rather than following up to see, did we get your cervical cancer screening results back into our EHR? That's a medical case manager's task. A CHW role would be, how did it feel to have your healthcare resolved at that visit? Do you feel more confident in being able to continue this kind of care? CHWs can also and are expected to be part of the care team case conferencing, so that when you're discussing patients and clients and developing plans for them, that the CHW is there to help inform and guide that plan by not only bringing their lived experience of receiving this care, but also bringing that full narrative of the client and patient that we spoke about earlier. And then again, they can also provide that affiliational and network support, really helping guide clients and patients back into supportive communities as a way to make sure that the people around them are supporting them in a way that helps them achieve the goals that they have set for themselves. So one of the things that we kept hearing throughout this BHIP project, things like clients need immediate support in crisis, they shouldn't have to wait, and that wait time was taking too long. The patients have a hard time in accepting their diagnosis, and so we just can't convince them to go to healthcare. They don't want to go to mental health care. They don't think it's important. Or clients just aren't ready, and we don't know how to ready them. Or patients don't feel comfortable talking to new providers about these new parts of their care. They've told their story already, and they don't feel the need to tell it again. So this is when the CHWs bring back the old school. For those of you who have been working in HIV a long time, before we had any retroviral therapy, before we had our sophisticated systems, we had buddy programs. We had people whose job was to walk in the world with you. Often these people helped you prepare to die with dignity. They made sure that the harsh world around you hurt you less than it would without that buddy. You can bring back this concept of a buddy. Buddies can help you get ready for treatment. Buddies can talk to you about the importance of mental health care. They can share with you their own lived experience of how they have found it to be important. And more importantly, think about just being human. Does anybody like to go sit at the DMV for 5 hours alone? No, that's boring. Nobody wants to do that. It's why all of us avoid doing those tasks, and we do them at the very last minute. And sometimes now in our environment, they forbid you from using your cell phone, as if it could get any less exciting than to sit in a social service office where I can't even use my tools to communicate in the way with the world to make that 5-hour wait a little less painful. Well, the best way you can sort of enhance that experience, send somebody to go with you. Have someone accompany you there. Now, it's not that you can't do it yourself. It's that some people don't want to. Some people don't feel confident in going there, or they say, I've been there and nothing happened the last time I went. Sending someone with you can make that experience better. You're more likely to go. And then if anything goes wonky, you've got an advocate sitting right beside you who maybe can step up in a space where your experience hasn't gotten you to the place where you feel confident stepping up. Because I can tell you, our CHWs have no problem talking to other people about the needs of their patients and clients. They are fully aware of their role as advocates and are fierce advocates, especially when we move into social service systems, because sometimes those systems are built to frustrate you. They are built to see how long you will sit there to get that service. So the best part we've done is built a system to sit right beside you, to make sure that you get that service and that the person with you will advocate for that. Another thing that we heard recently in our BHIP learning session from our consumer liaisons were things related to, if I am there for my mental health, then focus on my mental health. Why do they always have to keep bringing up my HIV diagnosis? And other folks were saying, I've dealt with the HIV. I'm good there. So why do we always frame my mental health with HIV? These are things that are really critical to understand about people's experience of services. Many of us living with HIV have overcome that hurdle. We walk in the world as people living with HIV just fine. We've got the t-shirt, we've got the card, we've been on the advocacy train, we're good with that. What makes us uncomfortable is that maybe we have a substance use disorder that we don't want to talk about. Maybe we have a mental health disorder that we're ashamed of because we still stigmatize substance use and mental health care in ways that are sometimes harsher than what we do to HIV at this point. So what CHWs can also do is bring the community voice to you so that when you're thinking about what services should we give and how should we design those services and how should they go out the door, that a CHW can walk in and say, hey, psychiatrist, do you know what they don't want you to talk about? Their viral load. Do you know why? Because they go to their HIV care provider for that. What they want you to talk about is their mental health care. Because I've only got a 50-minute hour with you, and I want to make sure that those 50 minutes are spent on the reason I walked in the door, which was not because I had HIV. It was because I wanted to help myself in relation to my mental health. And I think speaking to CHWs about patient experience in this space can really help you not only tweak programs you already have, but make sure that what you're bringing in is what people are actually asking for and what they're needing. There is nothing worse than spending a lot of system effort and system time and employee time on a service that misaligns with what your community wants. And when we had our learning session and we heard this from our consumer liaison, it was a giant aha moment for people to really think about, have we become so HIV focused that we've lost the fact that these other parts of people's care, in their opinion, are sometimes more important. And maybe they don't want these two environments so mixed up. So really think about how a CHW could help there. So what I would also remind folks of are BHIPers. You're familiar with this WHO pyramid, I hope, at this time. And one of the things we keep driving home to people is the recognition that at the base of the pyramid, there's a lot of opportunities here. The spaces around self-care, the spaces around informal community care. These are informal services. This is CHW bread and butter. This is where they can do a lot of good. So when you're thinking about these two spaces, look inside your organization, especially those of you with CHWs, and ask yourself, are you leveraging your CHWs in these spaces? When we think about informational and instructional support, a lot of that is about self-care. How do we take care of ourselves out in the community? How do we care for ourselves in a way that sustains us in between our 6-month medical visits? How do I build the confidence in myself to go back to my therapist every month when I don't feel like I'm getting better? But we know that it's a lot of patience and persistence in those environments. And the people who are successful are the ones who have the confidence and the system access to keep going back. And they have the support around them, helping them when they feel like they're running out of energy. Also, this is a graphic that we introduced in our last learning session related specifically to substance abuse. And one of the things that we wanted to point out here too was, in this abstinence, low risk, and at-risk use spaces, there's a lot that CHWs can do here too. A lot of our systems are either you don't use or we have to send you to detox. There's a lot of space in between there. People don't become heroin addicts overnight, right? Generally, there is a process. There's a behavior that is slowly over time built. And so what we want to be able to do is recognize that if somebody has problematic use, before it moves to dependence, there are conversations that a CHW could have with someone about what's going on in their life. One of the things I always ask the CHWs is how well they think their sites are screening for substance use. Because we keep getting reports back saying, oh yeah, everybody's screened negative. And what I hear from the CHWs are half the waiting rooms are high, right? The reason they know this is because half of us used to get high. We know what that looks like. We see it and we recognize it. And so CHWs can help guide you and say, you know, I think you want to look at that screening a second time. I really think this individual is struggling here. Let me go have a conversation with them. Let me go ask them some questions. CHWs, because of their trust and their credibility in the community, their ability to speak to people in a different language, are likely sometimes to get information that a health professional won't. And what we want to be able to do is get information that saves people's lives. And when we're talking about substance use, particularly opioid use and this phase of our culture, you could save a person's life by having an informal conversation and becoming aware of a need that they have before that problem gets even more serious. So when you look at potential CHW roles and BHIP referrals, First and foremost, you can think about educating patients and clients on the importance of behavioral health and behavioral health services. Not all of us come from spaces where we were taught that mental health is important. A lot of us come from communities where we were told not to talk about it, where we were told if you have a problem, deal with it, and definitely don't discuss it. We can start unlocking the stigmatization of persons with mental health disorders, persons with substance use disorders, by bringing that conversation forward and explaining to people how important it is that we have these conversations. They can support linkage and retention through emotional support and accompaniment to visits. If you want to make sure the person gets to that visit, have someone go with them, because you'll know that day when they didn't go, or you'll know that day when they sat in that waiting room and someone said something so disrespectful to them that they walked out, and you'll know why they walked out. Because sometimes we lose people in their HIV care when someone else in the system treats them disrespectfully. And I'm particularly speaking to some of the stigmatization and discrimination that transgender women face in our systems that are still not appropriate to their needs. What we see, the stigmatization to our young gay and bisexual men, particularly our men of color, how their communities and the systems treat them. It's very important that we attend to that at the visit level as well. They can follow up on referrals and visits to check the temperature of the patient or the client. Did you understand what everyone just talked about? Were you able to do the things that you have in your plan? And did the provider treat you well? Most people should be able to walk out of their visit and feel better about themselves, feel better about their health care. And if that didn't happen, that means there are opportunities that we could do something better next time. They can also provide emergency and recovery transportation services so that if logistic care fails gloriously, which they are known to do, we have a way to step in and disrupt that process and bring the patient to the care that they need, get the client to the supportive service that we know is going to be critical to them being sustained in care. CHWs can provide recommendations to care teams on how to better engage patients and clients. By knowing that whole story, they can tell you where the healthcare system is messed up in the past and maybe where we need to do something a little different in the future. Re-engagement can look very different than engagement. And sometimes it's about apologies and it's about reapproaching a situation with a little bit more humility and understanding that we have to go back in and approach people as individuals. It's very difficult to standardize humans. We standardize processes, not patients. Lastly, CHWs can also test your referral and linkage processes. If you want to know how well your system is screening for depression, put us through the screening. Test on us. We're the people in the system that can help support this. If you want to know what it's like to be linked to care outside, ask the people in your system who have had to be linked to care outside. I can tell you personally what it's like trying to sustain myself in a dental home. I had to reach out to my own CHW to make sure that I stay in that care. I find it incredibly challenging. And these are lenses that are critical to understanding how difficult it is to access healthcare these days. We are not sending CHWs to sell patients on a really impossibly fractured system. What we are sending CHWs to do is save them from our impossibly complicated and fractured systems. So the last thing that I wanted to do today was just spotlight one example of how we've seen CHWs be leveraged into the referral space. And this started actually with an email that we received from Dr. Stephen Toth, who's one of the professors of dental medicine who works at the Rutgers Ryan White funded dental program. And he was working with the CHW from AtlantiCare and sent us a note saying how much the care had shifted in his environment as a result of his interaction with the CHW. What he pointed out was that from June of 2018 to May of 2019, that CHWs working with his site had successfully located 37 totally lost to care patients. And as Dr. Stevens said, these 37 patients completely ghosted us. If not for the CHWs, they would be gone, poof, right? These are folks that they had tried everything, postcards, phone calls, letters, follow-up. They'd done everything their system knew to do to reach out to these folks. They had exhausted their in-house tracking options, and they left it up to the CHWs. And here's what the CHWs were able to do. They were able to successfully locate and re-bring into their dental home 20 of those 37 people. 8 of the patients remain completely unreachable, still off-grid, even for the CHWs. 2 of the patients were actually identified as deceased, so think about how discomforting some of those postcards and letters may have been to their families who were receiving letters for someone who had passed away. And 7 of the patients were actually located, but were not ready for the continuation of dental services yet. So the CHWs continue to follow up. The Rook Oak Dental Site, working with these CHWs, routinely sees 200 unduplicated patients, which means the return of 20 additional patients to their dental home resulted in a 10% increase for them. That is really amazing. And when we start thinking about the number of referrals that are not followed up on in behavioral health services, the number of people who go and don't come back, the number of people that their mental health or substance use provider can't find, that CHWs could step into this space. And not only are we seeing evidence that this works in another one of our referral environments, referral to dental services, we think that you could be leveraging your community health workers into this space as well. So when you think about a referral to mental health care, trigger a supportive role for the CHW. Let them know you've made that referral. Let them know when the visit is so that they can follow up, or they can call them in advance. Hey, I know you're going to see a mental health provider tomorrow, and I just wanted to check in and say, 1, I'm really proud of you for stepping into this space and taking care of yourself. And 2, I just want to check in and see, how do you feel about this? How are you doing? Sometimes people are nervous, and I just want to make sure that you're completely comfortable with what you're doing tomorrow. And oh, by the way, would you like someone to go with you? Because if so, let me know, and one of our CHWs here will make the time to be present with you, to be a witness to what you're going through, and to make sure that tomorrow goes well for you. I think at the end of the day, what we want to communicate to you is that CHWs are the intervention, right? They don't need an evidence-based program to implement in your system. They are the evidence-based program. Simply having CHWs in your space, communicating with your patients and clients, doing what they do on a human level affects a person's experience. They affect that experience in such a way that it improves retention and engagement to care. We are seeing this all across the country, and we're even seeing it here in New Jersey. I could have highlighted 1,000 CHW stories from across the state. We're seeing it in all of our environments. So if you have any questions about how you could better leverage a CHW, or what more you could be doing in this environment, please feel comfortable to reach out to us. Myself, along with Jerry Summers, who I'm sorry couldn't join us today, but who is another person who deserves an incredible amount of accolades and thanks for her genius behind some of the structure of this program. The 2 of us are here to help you. Cynthia Memo from the state is our contact there. You can reach out to your PMO and ask for support in this environment. We're more than happy to provide it, either from the BHIP side or from the CHW side as well. And if you don't have CHWs in your environment, I would highly encourage you to think about it and speak to your PMO about when is the next time you would be able to apply for CHWs for your own environment. And if you find that they're working and you need more of them, let them know that, right? Communicate back the good work that your CHWs are doing. So with that, I will open it up for any questions or comments that folks may have related to leveraging CHWs into your behavioral health networks. And you can either raise your hand, you can use the chat room, or you can unmute yourself and ask your question live. And I see some of our CHWs here: Latoya, Chloe, Jordan, Isam. I am proud of all y'all. Gloria, Raymond and Rwanda, Oscar. Hey. So I see a question from Ava. What do clinic setting agencies do with CHW during ID visit days? This is a really great question. So 1, if you're in a team-based environment, I see a lot of folks who include their CHWs in morning huddles, right? So they're part of the preparation for the clinic visit day. They are also being used to either speak with the patient in the waiting room while they're waiting for their visit. If your clinic flows behind by 45 minutes, they can help make sure that that person isn't steaming mad by the time they get in to see you. They also do check-ins with the patients or clients after the ID visit, right? Did you understand everything that was just done? What did the doctor say? Do you have any additional questions? Is there any other way I could support you? So they do almost like a post-visit check-in. Also, some ID providers schedule time with the CHW. They say, hey, you know, I see that adherence is challenging. I know the medical case manager has talked to you about this. I'd love it if you could sit down with our CHW for a little while. They've got some great ideas that they could provide. And I see, Rwanda, you got a comment?
I do, Adam. I just didn't want to be rude.
No, come on in.
One of the great aspects of us here at the A-Team is, if you remember, almost 2 years ago, we were the CHWs that were relegated to a corner. And if you remember how hard you helped us to fight, we are fully integrated in our team process, and all of the things that you've talked about today, as well as what we do during clinic days. I'm just really grateful to say that on some clinic days, we get to see 20 patients as CHWs, just providing the emotional support or finding out how they're doing or what they need and things of that nature. And it's just super cool.
Absolutely. And I would say, one, that I didn't help you guys do that. You demonstrated your value in those environments, and your organizations valued what you do, and you guys earned your right in that space. And I could not be more proud of the work that all of you have done. As a healthcare professional working in this environment for over a decade, there is nothing I'm more proud of than what you guys have done as CHWs in this environment. You are changing people's lives, and I am eternally grateful for what you do for me and everyone else in our community.
Thank you.
You're most welcome. Thank you. So I know we're coming up on the hour, so the last thing that I wanted to do before I forget is remind everyone about our BHIP provider and team survey. Some of you have probably received an email. You may have received it multiple times. If you have already completed the survey, you don't need to complete it again. But if you have not done so yet, or there are members of your staff that you've not disseminated the survey to, please feel free to share this link. We have the link in these slides. They'll be available on Basecamp after this. Greg has put the link into the chat room as well. Please click that link and take that survey. We're going to use these data, and we'll share them back to you at a future learning session. And we're going to use them to continue to tailor our training and capacity building offering so that we're hitting things that are important to you and are needed by your site. And also here, if you ever have any questions or anything about the BHIP project in general, our last slide always has contact information for Greg and myself. Feel free to reach out to either one of us with any of your questions or concerns. It's our job to make sure that we are supporting you in an effective way, and that you are being supported as sites, because we know that this is a really difficult thing to change your entire system, and we value that you are here. We hear you in all of your challenges, and we are here to help you with that. So I will thank everyone for coming out today. We really appreciate the time away, and we'll be here for a couple minutes if folks have any other questions, but if not, enjoy the rest of your Wednesday. And stop the recording.